We will now be moving on to the next session done by British Association of Urological Surgeons. To moderate this session, may I invite Professor Ian Pearce and Dr. Manjula Vijayawardena. Our focus in this next session will be A to Z in andrology.
Okay. Good afternoon, everybody. Thank you for those who've come back from lunch promptly, all 10 of you. I'm sure everybody else will be floating in and out as we proceed for the next hour or so. It's a real pleasure to be here. Thank you very much for inviting me. I'm very proud to be able to represent BAUS in the BAUS SLAUS Symposium for the next hour or so. We are going to hold a program looking really at updating everybody in the field of andrology. We've got three exciting talks, but as one of them is mine, I feel I should say we've got 2 exciting talks, and then I'm going to do the third one. So we've got 2 excellent colleagues, one from the UK, Pippa Sangster, who's in the audience, who's going to come up and talk about infertility updates. And we've got Ajith Malalasekera from here in Colombo, who's going to talk about Peyronie's disease. And I will be talking about an update on erectile dysfunction. So hopefully, over the course of the next hour, we will have something for everyone, and everyone will feel nice and updated. And what we're hopefully going to do is to go through all the 3 talks, and then we'll take any questions at the end with everybody up on the stage, if that's okay. And I'm very proud to be able to co-chair this with Manjula, the president of SLAUS.
As tradition goes, a presenter can't present himself as an introduction also. So I'm going to introduce Professor Ian Pearce, the visiting president of British Association of Urological Surgeons, who is leading this symposium and it's being its first speaker. He has had enough introductions in our session for long. So without much ado, I call upon the professor to give his lecture.
Angela, thank you very much. I'm never quite sure whether speaking first after lunch is a good thing, because I'm assuming everybody else is feeling as sleepy as I am, but equally that also means that there are fewer people here and fewer questions. So I'll probably just take it as good fortune. So I'm going to talk about erectile dysfunction, and rather than go through everything we know about erectile dysfunction and take people through back to their medical school days, I'm really going to try and concentrate on the literature over the last couple of years. So very much what is coming up, what is out there, what we might think that we need to deliver for our patients, and what might be early in the guidelines, or maybe even making the guidelines in the future. So I've looked through PubMed from the last couple of years, so essentially 22, 23, and 24. And it won't surprise anyone to know that there's quite a lot out there. If you look at the graph of publications across the field of andrology, what you'll find is it sort of grumbles along a bit. Then when we get to Viagra, it goes up a bit. And then since then, it's sort of exponentially rising in literally all fields. So it's of no surprise that there's been over 3,000 publications. Rather than give you chapter and verse on every single one of those, which clearly I wouldn't be able to do, I've tried to look at those studies that were really well conducted, the robust RCTs, and also the meta-analyses and the systematic reviews, really so we can get a proper, robust picture of what's going on. And what sort of comes to light, really, is that there are possibly 3 things on the horizon: Botox, platelet-rich plasma, and lithotripsy, low-intensity focused shockwave lithotripsy. So I want to take you through those 3, and also finish with a little bit about recent publications relating to penile prosthesis surgery and outcomes. So if we think about Botox, this is a study from February 2022, randomized controlled trial, so nicely conducted, very well designed, 70 men. And the key here isn't that there are 70 of them, but that they're all refractory to PDE5 inhibitors. So these guys have all tried sildenafil or tadalafil, etc. 100 units of Botox in 2 mils of saline injected straight into the corpora, in exactly the same way that we would teach people to inject, whether they're using Invicor or Cavaject, prostaglandin, anything at all. And what this showed, really, was that the erection hardness scale, the peak systolic velocity and the end systolic velocity were all significantly improved at 2 weeks. At 6 and at 12 months, they had a significant improvement in their shim, and that was significant compared to any of the placebo patients included. 53%, this is what I think is the most important thing. We can talk about scoring systems, we can talk about velocities, erection hardness, but actually that means nothing to a patient. What is important to a patient is whether they can have sexual activity. And over half of these people were able to have intercourse after an injection of Botox. This is something on the horizon. The EAU updated their guidelines earlier this year in April. And you'll just see here the third point down is that there is a new recommendation with respect to Botox. So I should say that their conclusion is that larger trials are required, okay? But the results are promising. So I think if we watch this space, eventually this will hopefully come to fruition. Lithotripsy, we've flirted in andrology with lithotripsy for quite some time. We initially tried to use it for Peyronie's, and this time we're trying to use it really to sort of stimulate angiogenic growth. There's been a huge amount of publications going on regarding low-intensity shockwave therapy, 9 trials, a few meta-analyses, and of course, as is always the way, everything varies. The design, the follow-up, the protocol, the etiology of the erectile dysfunction, you name it, it varies. So it's not always quite clear exactly what to take away. If you do go through everything, what you find that there are a few consistent things regardless of that variability. The IIEF at 3 months is significantly better. Great. But of course, what that doesn't say is what is the regime we should use? And clearly we don't know because that varied too much. But it looks like it does work. Up to a 25% increase in the IIEF. 26% of people experienced more than a 4-point increase because don't forget, you have to have a certain level of increase for that to be clinically appreciated by the patient and their partner. But interestingly, what is also becoming clear is that it may well be that the benefit is very short-lived. We just don't know. At least one study there suggested that no benefit after 6 months of treatment. And as time's gone on, there have been different studies that have looked at combining low-intensity shockwave treatment with a variety of other agents, and again, all with fairly promising results. The meta-analyses that are out there show, again, significant improvement in all of these scoring mechanisms. What they don't look, however, is to determine whether there is an improved ability to engage in sexual activity and penetrative intercourse. The EAU guidelines are weak, or rather their recommendation is weak, and they have suggested that we can use low-intensity shockwave treatment with or without PDE5 inhibitor, provided the patient is either not suitable for other methods or is appropriately counselled. Okay, so I think this is something that as time goes on, we'll get a clearer picture as to whether this is a short-lived phenomena, whether it is in fact lasting, and whether there is an appropriate or perhaps optimal combination therapy that we may be able to use. So definitely something that we should be looking at. Platelet-rich plasma, there's a lot about this going on in the States, not so much in the UK. It's not something that I think any of us have particularly engaged with so far, but it is still very early days. This was the original sort of study here, looking, again, RCT, double blind, and this was Masterson's unit back in 2023. The protocol obviously varies as well. There are 2 injections, 1 month apart, and they had almost 70 patients. And again, you can see here that the mean increase in the IIEF. However, those increases were not statistically significant. So on the basis of this, yes, it was safe, but possibly not as effective as we would like. There has been another publication, over 100 patients in this study here, and these were all patients with mild to moderate ED. This time, however, a significant increase in the IIEF. At 1, 3, and at 6 months, okay? And the minimal clinically important difference was also significantly better. So perhaps then we do have a bit of conflicting evidence at the present time. Meta-analyses, yes, because don't forget, although I've only shown you 2 studies, they were the most recent. There's a bit of data on platelet-rich plasma injections much earlier on than 2022. And again, variable trial design, which I think is a criticism of a lot of the literature out there, but significant improvements at 1, 3, and 6 months, and the end diastolic and peak systolic velocity, again, increased. All very good markers. And again, it may well be that as time goes on, we will get a bit more of a clearer picture, and without question, larger trials are required. What does the EAU say? Well, they say at the present time, don't use platelet-rich plasma outside the confines of a clinical trial. I think we'd all accept that that's pretty sound advice, even though they've put that down as a weak recommendation. The evidence is not there that for us to go along and use this without collecting data and using it as a study. I thought we'd move on to penile prostheses because there's a nice couple of papers I'd like to talk about. This is Ambrose Paré, who is credited with the very first penile prosthesis. And this, of course, is hundreds and hundreds of years ago now. Almost makes the rest of us pale into insignificance. And he looked at prostheses across the patch, not just for the penis. This was his original description of a penile prosthesis. I won't read that out, but I'm sure you can all see that. A yard was an Elizabethan term for a penis. But in fact, he used this as a penile prosthesis, not for sexual function, but actually almost as a male shiwi. He was using it to direct the flow of urine. And obviously, we've come a long way since then, haven't we? Everybody in andrology will recognize this as Brantley Scott, who was the inventor of the penile prosthesis. It actually came as an offshoot of his real interest, and that was the artificial urinary sphincter. So, like a lot of things, maybe it wasn't his passion, but it certainly is the thing that he's become most famous for. And the IPP has been around now for over 50 years. I've put in a couple of figures here. In the United States, there are over 25,000 implants a year. And don't forget, their population is around about 360 million. In the UK, we have a population of about 60 million, and we're putting in 400. So you don't need to be a maths genius to find that there is a massive geographical variation in terms of implants per head of population. And clearly, in the UK, we are under-implanting, I think. The other big hitter for implant surgery, of course, is South Korea. They're also doing an enormous number. So this is the penile prosthesis. And there are 2 good publications from this year really looking at quality of life. The Qual SPP is the quality of life and sexuality with penile prosthesis. So this is a bespoke scoring mechanism. And what that showed, actually, unsurprisingly, I think, to all of us who are doing implants, is that a patient's quality of life with respect to sexuality is vastly improved if they have a penile prosthesis. And of course, that stands to reason, because without the penile prosthesis, the majority of men can't achieve any sexual function at all. So certainly in the UK, almost all patients who are progressed to penile implant surgery have tried pretty much every other form of therapy before they get to an implant. Not all, and I think we are changing that, but certainly it wouldn't surprise anyone to know that your quality of life is significantly better. The other study really looked at the difference between inflatable and malleable prostheses, and there's no question that patient satisfaction, partner satisfaction, is significantly better for those patients who have an inflatable prosthesis. However, the mechanical failure rate, of course, is much higher. And again, that stands to reason, because with the exception of erosion, infection, and perhaps even breaking of a malleable implant, all of the mechanical failures are due to the inflatable pump and the mechanism behind the release. So, higher patient satisfaction, but certainly higher complication rate. And interestingly, no difference in infection rates or indeed ease of use. And we used to cite having a malleable because they were easy. And of course, they're easy if you haven't got dexterous function. If you've got a tremor, if you've had a stroke, yes. But otherwise, and accounting for that, there is no difference in ease of use. So we can't really, I think, be looking to put increasing number of malleables in because we think they're a bit easier for the patient. I would say now, in our experience, or certainly in our practice, 2 or 3% are actually malleables. Even post-priapisms, we're putting inflatables in. So if I move on just to do a quick summary here, Botox, certainly on the results that we've got, Botox looks promising. I think Botox will be something, certainly in the next 5 or 10 years, that we will have a much clearer picture on. And I very much hope that lasting picture is that this will be another thing that we can use to try and treat our patients with ED. The same, I think, for low-intensity shockwave treatment. I think probably the future lies in combination treatment. I think the evidence probably for solo use won't be quite as good. I think the results of combination are much more promising, and I think we will see an emergence of that. I think platelet-rich plasma, I think the jury is still out. I think there is conflicting evidence. There will be more studies. I think it's probably a bit too early to know whether that is going to be a lasting impact for us. And the final thing, of course, is that with penile prostheses, I think the inflatable is still king. I think that should be the go-to. And that's everything I have. Thank you very much for listening.
Thank you, Ian. You can sit with the moderator. Next, we'll take the questions at the end so that you'll have ample time. Next speaker is Miss Philippa Sangster. Pippa has convinced Richard to interrupt their very private holiday through the Paradise Island to celebrate with us our 25th anniversary annual academic sessions. She is a veteran at our meeting. So over to you, Pippa. We are very thankful for you to turning up today. Thank you.
Thank you for letting me come and speak. This is, without a doubt, my favourite conference to come to. So I'm going to talk about the infertile male, not quite so much as an update, i.e. what has changed, but more to really push the fact that we as urologists should be looking after these men. And historically, these men have not been looked after by us. And if there is a factor or there's a problem with the sperm count, it was fixed by the gynecologists and IVF. So I'm going to run through very quickly what to do if someone were to come into your office struggling to fall pregnant, and things that you can do to possibly help them. So when it comes to male infertility, there are a number of factors that we can look at, whether there is a medical thing that we can do, whether there are blood tests that can be taken, surgical options, and counselling. Psychological counselling for these men and as a couple is very important. It's very important to reiterate this is a vulnerable group, and so they're open to having a lot of unnecessary and very expensive investigations and treatments, which often don't do a huge amount. So is there a problem? Is there a problem with infertility, and is it increasing? We keep seeing articles saying that the sperm counts are dropping, infertility rates are going up, and that's definitely something that's becoming more visible as people are becoming more knowledgeable about it. We're getting tests, and there is significant tests now starting to show that there is a problem with men's sperm counts. In the UK, 1 in 7 couples will face problems with fertility, and in Europe, 18 million. There's very little evidence out there in regards to Sri Lanka and fertility rates. So there's been one good paper recently which actually looked more at a couple, so the female sides and gynecologists, and actually their rates were fairly similar, so also 1 in 7. And they found increasing risks, often to do with the woman because of higher education, so more likely to be an older woman, more likely to be employed, higher age, and also Muslim countries having less rates of fertility, potentially because they were getting married and having babies younger. So why do we bother evaluating the male? If someone has some sperm in their ejaculate, why not just go through IVF? Well, I think it's probably very important to say that IVF is incredibly expensive. So are there things that we can do to maybe improve sperm counts, to downgrade what they need to have in terms of the different options open to them with assisted reproductive cycles? We can diagnose genetic problems, which is important to know because they can pass it on to their sons. We can do surgical reconstruction. So as surgeons in the room, there's some amazing operations we can do. And also treating medical comorbidities. And there is increasing data to show that the infertile male has more likely to have a shorter lifespan, more likely to have male health problems. And so when someone walks through my door with infertility, I'm not just trying to fix their sperm count, I'm trying to see what can I do to improve their lifetime. This is a very important slide. It's a very miserable slide for women to see, but it's important that we start educating women to be having children younger. In the UK, we spend a lot of time going into school saying, be careful, contraception, don't get pregnant. It's put into us from such a young age, do not get pregnant. And actually, our careers are becoming important. Meeting someone is going on longer in life. But you have to think that once you hit 35, the chance of falling pregnant naturally as a woman is going down significantly. And one of the things that I think frightens a lot of my couples who come through the door, that if you're a 40-year-old woman, the chance of falling pregnant is less than 5% without some form of help. Those are really big numbers, so we should be pushing to start to say we should be thinking about having children earlier. So how to approach a male with infertility who walks through in your clinic. So just like anything that you would have learnt at medical school, so your basic history is very important. Oh, jumping along, sorry. I want to know if they've had surgery, hernias. You can be amazed how people can get their vases tied off an obstruction. What is their erections like? Are there things that we can do to help with the erectile dysfunction? Ian's gone into that very comprehensively, but a lot of our couples who come and see me with infertility will say, I'm starting to struggle with having sex, getting an erection. The psychosexual side of trying to get your partner pregnant after a number of months of trying can't be underplayed. We want to look for infections, again, infections causing obstruction, which might have a surgical outcome. Treatments for malignancy that may have an effect on the sperm analysis. And what are they doing in the gym? Young people like going to the gym, they like exercising. If someone's walking through their door and turning sideways because they're so big, what are you taking in the gym? What are protein supplements we're taking? So protein supplements can have extra things that we're not expecting, testosterone, which might affect their fertility. Again, important to educate patients. So when we do the investigations, semen analysis is king. It'll give us the first bit of information about it. If it's abnormal, repeat it again after at least 8 weeks. If they've been poorly, if they've had a high fever, if they've had COVID, all of these things can have quite a negative effect on the semen analysis. Blood tests, make sure you're doing early morning hormones. Imaging is appropriate, we'll talk a little bit about that. And genetics or sperm concentration dependent. So these are expensive tests, and the guidelines across the world are showing more and more now that maybe we don't need to be organising these expensive tests as often as we were. So when you approach your infertile male, I split them up into someone who has no sperm, potentially one of the easier ones to think about how we sort out. Someone who has abnormal semen analysis, can I make it better? And I think that's something that we can all do in the room. And then one of the hardest ones is they've got a normal semen analysis, a young partner, why aren't they falling pregnant? So semen analysis, you need a good qualified lab. You have to have an accredited lab. And I get semen analysis sent from me from all across the world, and we will often have to disregard it and move to an accredited lab where it can be very different. It can be quite helpful in that if you have a good lab, they can be telling you this is appropriate for normal contraception, IUI, IVF, or ICSI. There are a number of long terminologies I'm not going to go into, but one of the key things for the trainees to know is that many of your infertile couples will come in knowing more than you do about fertility, particularly as urologists. If stones or something else is your interest, you might not know all these words, and your patients often will. They know what they're talking about. So the semen analysis values have changed very significantly over the last 25 years, with the last WHO laboratory findings changing more in regards to talking about morphology and how the labs can discuss the different semen analysis. I wouldn't suggest that anyone is reading this for long periods of time, but it is important to know about how you produce your semen analysis. For me, abstinence is key. So if someone is coming and they're producing their semen sample and they've waited 5 days or 10 days, you can understand how maybe in your mind a man might think, right, well, if I don't ejaculate for a week or two, I'll have lots more sperm and it'll look better. You have to educate them that all you're going to end up is lots of dead sperm, lots of poor morphology, poor motility. So I don't want it ever to be longer than 2 days. And I normally ask my patients to make sure they masturbate either the day before or 2 days before producing a sample. If the volume is low, remember to ask, did they manage to catch everything? It can be quite difficult. My videos haven't worked, so I'm going to jump through. And just to comment on the morphology, because it's the thing that worries our patients the most. So morphology, normal volume is above 4%, with most men about 6 to 7% if they're falling pregnant easily and quickly. It's the one that patients come through terrified. I've got a morphology of 0% or 1%. It's very subjective. It's very much dependent on the lab. And so it's the one I try and stay away from worrying patients too much about, because it does not actually have an outcome on whether an IVF cycle will be successful or not. There's a real lack of scientific consensus on morphology. Variability. I love a crazy scientist. This crazy scientist decided to look at his semen concentration every other week. And you can see how the concentration varies dramatically month on month, whether he'd been unwell, tired, or the rest. So just to reassure patients, things can change. And if you've been poorly or unwell, we need to make changes to your lifestyle and repeat it. So semen analysis is useful, but it's not the be-all and end-all. It's a really basic picture to show a room full of urologists, and I apologize, but it's just to explain that when you're examining our patients, you need to examine infertility patients lying down. I then make them stand up, and I have small talk chat for at least 2 minutes where they feel quite uncomfortable standing there half naked. But you've got to give them the opportunity to stand up to see what changes, because a varicocele will become much more obvious after a couple of minutes. Do they have a VAS? You'll be amazed the number of men who come, who've been examined by someone and no one has picked up that they didn't have a VAS, or it wasn't an epididymal cyst, but he's got big obstructed epididymis. So the examination is really important. And what we have thought about varicoceles and fertility has changed very dramatically over the last 10 years. And EAU guidelines catching up with this very quickly. And we now say that if a couple is struggling to fall pregnant and a man has a clinical varicocele, we should be considering treating that varicocele to improve sperm parameters. Same too with adolescents. So if an adolescent presents and he's got a large varicocele, we have tended to wait and look at the size discrepancy between the two testicles, and if it's more than 20%, treat. It's very difficult when you're looking at young teenagers, so 13 or 14-year-olds. We're not going to be sending them off to do a semen analysis. But if I see an older adolescent, 17 or 18, who's masturbating frequently, I will get a semen analysis to guide me on that treatment. So the EAU guidelines, and they were updated this year, and I have to say, if you've not looked at the reproductive guidelines, they are fantastic. The only page I don't like is the page on the treatment and what are the best options. So you obviously have to treat the varicocele how you have access to it, and surgery is potentially a lot cheaper than embolization. But in our hands, we've looked very close at our data, looking at surgery and embolization, and we found that actually the success rates and improvements in sperm parameters were almost the same, if not slightly better for embolization. So I will tell all men, it's up to you. You can obviously have an operation, but that's a general anesthetic, a cut in the groin, and a month of heavy lifting, versus the embolization, which is 45 minutes, back to work the next day, and from our point of view, minimal risks in terms of not being able to damage the testicle artery. I always have to caveat that up by saying, look, I should warn you, my husband is the interventional radiologist and I'm the surgeon, but maybe that means that I can give quite a balanced point of view. But that's not what the guidelines say. They're very much saying that the microsurgery treatment option is better. So talking about the blood tests, we do our blood tests, our early morning testosterone, FSH and LH. We want to know, is there a problem with the testicles or is there a problem with the pituitary and the testicles not talking to each other? So secondary hypogonadism, so someone has a really poor sperm count or they have no sperm count and small testicles, I want to see that the FSH is really high. I'm sure you all remember from medical school days that the pituitary produces FSH to stimulate the sperm, LH produces the testosterone. So if the testicles are not functioning properly and they're not making sperm, I want the pituitary to be pouring out FSH. And it's the men who don't have that discussion going on between the pituitary and the testicle that are quite interesting and that we can manipulate very easily with medications to try and push spermatogenesis with fairly inexpensive medication. And this is why these blood tests are very important. And I think for some people, historically, they've worried that actually this FSH blood test, whatever this is bad for the testicles. It's not. It's the discussion that the brain and the testicles are having. So the blood test will give us an idea of what's going on between the brain and the testicles, and for me, it gives me an indication of what can I do to try and medically stimulate these patients. Always trying to think, what can we do to try and minimize the cost of IVF? So can I give them a really cheap medicine? So if someone has a lowish or a borderline low testosterone, but their FSH is also really low, these are the patients who will really respond to stimulation in about 70% of the time. And you can see it's a busy slide, and I apologize, but there's many different medications, be it HCG, FSH, clomiphene, aromatase inhibitors. But for me, the one I use most commonly is clomiphene. And clomiphene is really cheap in the UK, so I should be able to do £30 for 3 months. And they take 50 milligrams every other day. You can't just give a patient clomiphene and say, goodbye, I'll see you in 3 months. You've got to see, is this the patient that's responding to clomiphene? So they'll all come back and have a blood test with me after 6 weeks, so I can make sure to see that their LH and FSH is responding and climbing. If it's not, you're wasting their time, so stop. So there is potentially evidence coming through that we should be treating patients with isolated FSH if their FSH is low and their brain is not screaming. But this is expensive, it's patients injecting themselves twice a week, and the research is not there. But hopefully that will come in the next few years. So as I said, what I do, so men who have a low borderline testosterone, a low FSH, I treat with clomiphene. If they don't respond to clomiphene, or their testosterone is really low, so we're talking sub 6 nanomoles per litre, I will often start with HCG, and that will be particularly for some of the unusual genetic syndromes such as Klinefelter's. So to run in really easy advice that you can give your patients, so many patients will come And they'll say, what can I do in my life to try and produce better sperm quality? So we talk a little bit about alcohol. Alcohol has much more of an effect on women's fertility than it does for males' infertility. So I say, look, if you're having 4 or 5 units spread over the course of the week, it hasn't been shown to have any massive effects on the spermatogenesis. If you do what the typical British man does and go out on Friday night and have 20 units, that big bang of alcohol is very bad for sperm. So it's all in moderation and low numbers. Smoking, clear data. So smoking will decrease your concentration, your motility, and your morphology. It can be very difficult for patients to stop smoking, but quite an easy way to explain it to them is, look, you're making sperm and it takes 3 months. Think of yourself as pregnant for 3 months. When your wife is pregnant, she will not smoke. So everything you're putting into your body for that 3 months while we're trying and improving your spermatogenesis, and that can sometimes help them just stop the smoking. And the same goes for e-cigarettes and vaping. Increasing evidence that the vapes, because we don't know what chemicals are in them, are having a negative effect, particularly on motility. So the vapes are hugely variable from shop to shop. They have very different chemicals in them, nicotine, but a number of other chemicals that can have a negative effect on sperm. So again, my pregnancy retaliation comes out. Exercise. Is exercise a good thing or a bad thing? No, actually, gentle exercise, regular exercise is a good thing. But anything that pushes patients to an extreme level, so extreme athletes, people who are running triathlons, marathons, anything where you're becoming catabolic and losing weight has a negative effect on your sperm. I tend to say stay away from cycling because if you imagine that bicycle seat pushing up in the scrotum, I have visions of men in lycra, anything that's going to overheat the testicle is bad. But gentle running, swimming, exercise is all good for sperm and good for men's health. So very quickly in the last few minutes, the surgical options. What's available out there in Sri Lanka, you need to have a good embryologist. So if someone has azoospermia and we're thinking about a surgical option, we should be operating with our embryologist in the room. It's your chance of giving your best outcome to your patients. So if someone is obstructed, so the testicles are producing sperm, but they're obstructed somewhere along the lines, very easy to carry out a PISA, so a percutaneous epididymal sperm aspiration, and I imagine the same as it is in the UK. It's the gynecologist that will often be doing this procedure. You can actually cause quite a bit of trauma and quite a bit of damage to the testicles, so you do need to know what you're doing, know what you're feeling. And there are times when you're putting the needle into the epididymis and you are getting out some sperm, but not enough sperm for multiple cycles of IVF. And then you might go towards the MESA, so the microscopic epididymal sperm aspiration in the lower picture, where actually you deliver the testicle and then you can pinpoint the needle into the epididymis. But what about men who are not obstructed, not producing sperm? So we know that if we open the testicle up, we can find little pockets of sperm. And if you are actually looking with a microscope, you can make the seminiferous tubules easier to see. They'll look thicker, whiter, more obvious, and I can pass them tubule by tubule to the embryologist and increase the success rate of finding sperm in men with non-obstructive azoospermia. So this is the conventional TZ. So it's a bit of a blind procedure in that you're making a 1 centimeter incision and we're taking a whole chunk of tissue and giving it to the embryologists. Whereas we're moving more now towards the micro TZ. It looks quite a vicious procedure, I have to say. So you basically open book the testicle. So it's a midline incision, open up the testicle, and then we bring in our operating microscope. It is totally able to do this with operating loops, which you might have more access to. And it means that not only are you pulling out the more healthy tubules, but actually you can avoid blood vessels and bleeding. We can also be really careful about our drying off blood vessels at the end of the procedure, because at the end of the operation and you're popping everything back in, if you have a bleeding testicle and an intratesticular hematoma, you can kill that testicle very easy. So it's important to spend time to make sure that everything is nice and dry at the end of the operation. So a very quick through male infertility, but just to sort of say again, male infertility should be looked after by the urologist. You should be taking control of these patients rather than the gynecologist, trying to improve men's sperm counts and maybe saving them money so that IVF and ICSI are not necessary. Thank you.
Philippa, thank you very much. That was fantastic, very clear, very informative, brilliant, thank you. We are taking questions at the end, so could I ask you to take a seat on the hot stage? Thank you very much. So for our final speaker, it's a real pleasure for me to be able to introduce a local person. somebody who is the Professor of Urology in Colombo, Ajith Malalasekera, who is also Treasurer of SLAUS and a former editor of the Sri Lankan Journal of Surgery. And Ajith describes himself as a core urologist with an interest in andrology, which I think is probably what most of us call ourselves. So Ajith is going to talk to us about Peyronie's disease and surgical management. Ajith, thank you.
Thank you very much, Ian, and thank you to BAUS and SLAUS for this wonderful opportunity to speak on the surgical management of Peyronie's disease. Francois Chigo de la Peyronie is credited with the first documented description of treatment of Peyronie's disease, even though there have been descriptions of Peyronie's disease from far back as the 13th century. We have learned and understood about the pathophysiology and the etiology of Peyronie's disease, and also a lot about the conservative management of, or non-surgical management of Peyronie's, especially with intralesional injections. However, there is definitely an indication for certain patients with severe degrees of disease who will benefit from surgical intervention. So for whom is this intervention required? Firstly, the patient must desire surgery. They must have tried some of the other methods and had poor responses, so it's a desire of the patient to proceed to surgery that's quite important. And also, surgery is indicated in a patient once they have progressed from the acute phase of the disease to a chronic phase, generally beyond about 1 year of symptomatic phase. And also their deformity must be stable, generally at least beyond 3 to 6 months of being stable with, for example, the curvature, etc. And also there are other factors that we need to clearly understand and look at before we check out and identify which form of surgery we offer our patients. The degree of curvature is important, and a cutoff mark of 60 to 70 degrees will make us decide whether plication versus incision or excision with grafting is indicated. Then, whether indentation is present. Is there an hourglass deformity or notching? Or do the patients describe a buckling of the penis? For example, you can also demonstrate that with injections where on axial pressure being exerted, one will see the penis getting, having instability. Then, a very important factor to ask these patients is, how do they respond as far as erectile dysfunction is concerned? What is the rigidity they have with or without these curvature issues? So this busy slide will tell you an algorithm by Ziegelman, Levin, and others on sort of a pathway we can utilize to use in the management of surgical management of Peyronie's disease. So the factors I spoke to you about can be utilized. If I could have a point on this IT team. So the first thing is to decide the symptom duration. Is it beyond 1 year? The deformity, is it stable? And if it is in the chronic phase, then we should then ask the patient, discuss with the patient, what is their desire? Are they interested in considering surgery as an option? In which case, we can proceed to further evaluation and questioning about erectile function. If they are responding to oral PDE5 inhibitors, or they do not have overt risk factors for erectile dysfunction, like diabetes, severe atherosclerosis, etc., then they can be considered for either penile plication or incision and grafting surgery. Now, the decision between incision, excision, and grafting versus the probably simpler plication will depend on the angulation, the indentation present. Those are the two main things that we consider. So if the penile curvature is much more simpler, less than 60-70 degrees, then probably we can get away with a simpler plication procedure. While if the curvature is more complicated, more severe in degree beyond 60 to 70 degrees, or if there is a more complex curvature. Some patients have purely ventral or dorsal curvatures, but others will have lateral curvatures in combination as well. So those may be a little bit more difficult to correct with plication alone. So if the deformity is less in nature as far as the curvature and the indentation is absent, then penile plication is considered. Or if the angulation is more than 60-70 degrees and there is notching, hourglass deformity, etc., then a better way to go it would be penile incision or the tunical incision or excision with combined grafting. In those with overt problems of rigidity, despite PDE5 inhibitors, then the way to go forward would be with penile prosthesis insertion and manipulations. So as I mentioned, the three main categories of intervention are plication, incision, excision, and grafting, or penile prosthesis insertion with simultaneous manipulation procedures. So these is probably a simplification of it, the procedures that we can do. So going on to plication, even though I described that it is for more simpler curvatures, there are publications coming out, presentation of large case series where they have looked at plication procedures for even more complex lateral curvatures combined with ventral dorsal curvatures, or even more complex, more severe degrees of curvature, which have given reasonable results. If you look at the history and the evolution of plication procedures, Nesbitt was the first to describe these procedures with an excision, elliptical excision, and then suturing of the tunica. Then the Yachia procedure, where we would incise longitudinally and then suture horizontally, shortening the procedure exactly at the opposite point of the maximal curvature or the deformity. True corporal plication means an incision is made and plication is done, but there have been modifications by Essed and Schroeder, etc., who have described the application of plication sutures alone with inverting of the sutures to minimize the palpability of these sutures. Now, there have been modifications of these plication procedures. The TAP procedure, or the tunica albuginea plication, as described by Levin et al. In this procedure, what we actually do is make 2 incisions in the tunica albuginea, but these are not full incisions. It's a partial incision made on the superficial aspect of the tunica. A few millimeters, maybe 5 to 10 millimeters apart from each other. So partial incision, probably to the longitudinal fibers of the tunica is made. And if needed, you will excise the superficial tunical tissue in between these 2 incisions. And then after the procedure, to plicate this using a simple 2O polyester braided non-absorbable material. Further plication sutures can be inserted above that. The other plication procedure that has been described and has gained a lot of popularity is the LU 16 dot or 24 dot plication, again with non-observable braided sutures. So generally, degloving incision as well as exposure is what is proposed, and the penis is exposed, and the tunica is clearly exposed either in the ventral or dorsal aspects. And if the curvature is on you always obviously suture and shorten the penis on the opposite side of the curvature. And then in the ventral curvature aspect, the intention would be to mark the 16 dots starting from maybe 3 to 4 millimeters proximal from the coronal sulcus, extending right down to the penoscrotal junction. On the other hand, if it's being inserted on the dorsal aspect, there is a space created between the midline dorsal venous complex, the midline dorsal vein and the more laterally placed dorsal artery, and the sutures are placed again with 2O non-absorbable braided sutures. The general approach for this is a circumcision incision or a penile subcoronal incision with penile degloving. And there are other incisions described, for example, the penoscrotal incision, a short penoscrotal incision which have been described by authors, similar to the incision that we utilize sometimes in insertion of penile prosthesis. Now, one of the disadvantages of the plication procedure is the length loss. Obviously, what we are doing is, if there is a curvature, we try to shorten the penis on the other opposite surface, and that may compromise the length of penis in a patient who already has some shortening of the penis. So there has to be a lot of discussion with these patients on the possibility of shortening, which is objectively there in up to 20 to 40% of patients, and subjectively with patients in up to 75%. The method of plication, whether it's an incisional, excisional corporoplasty or simple plication technique, there is no strong evidence to say that one is better than the other. So whatever one is used to and comfortable with should work for you. Then incision and excision of plaques is more useful in patients who have severe deformities. The indentation may be better tackled with excision of plaques. However, we must remember that the complication rates of this can be as high as 67%, especially with erectile dysfunction. We must be careful and ensure that patients are clearly identified as far as any difficulty in having erectile dysfunction or the presence of risk factors for erectile dysfunction. Because we may operate on the patient today, but if they have a long history of being vasculopaths or having diabetes mellitus in 5-10 years, they may develop erectile dysfunction, and then they may ultimately have to undergo a penile prosthesis. So we need to counsel our patients and discuss with them before we go on to these patients. This is one of my patients who had a very significant penile deformity, close to 90-degree ventral curvature, and he had a incisional modified edge incision and graft utilizing a great saphenous patch. And so in this case, we have to mobilize the corpus spongiosum along with the urethra. But on the other hand, if the deformity is on the dorsal aspect, then we need to completely mobilize the dorsal neurovascular bundle to gain access to the deformity and make the incisions and apply the patches. Partial excision and grafting is a more complex procedure which will involve excision of the diseased, partial excision of the disease plaque, and it may be useful in certain patients who have more extensive deformities with girth and indentation, especially indentation deformities, and also in patients who have a very broad-based penile curvature. The most feared post-operative complication is erectile dysfunction, and the occurrence of this problem is very varied in publications and can range from 0 to 60 odd percent. And obviously, if there is a greater penile curvature, the risks are much more. And also, if in ventral curvatures, the chance of coming up with erectile dysfunction post-operatively is, as per evidence, considered to be much higher. So we must be very careful in counseling our patients beforehand and discussing about erectile dysfunction in these patients. So what are the grafts that are available for the patients who will need these? Autologous grafts are probably the commonest used grafts. The advantages are that they are readily available. The disadvantages are probably a much more increased operative time where we have to obtain the graft from the same patient. There can be graft contraction and also certain harvest site complications that could affect the outcome. Allografts and xenografts are available, of course, at greater expense. We do not commonly use these here in Sri Lanka, such as processed human pericardium and also the equine collagen fleas. One of the advantages of these is that the ability to apply this graft without needing to suture it, which has probable very useful advantages in placement over penile prosthesis, the inflatable penile prosthesis. Now, what about penile prosthesis insertion in Peyronie's disease? In the proper study, Kera et al. Clearly demonstrated that people
Ajith,
with
you
Peyronie's
need to speed up a
disease,
little bit, Ajith.
Yeah.
We got 3 minutes is a discussion
yeah,
time.
people have clearly demonstrated that with Peyronie's disease that it can reduce the depression levels in patients who have penile prosthesis inserted. And in most patients, in quite a lot of patients with penile prosthesis insertion and manual modeling, as described by Steve Wilson and others, can correct the deformity. In certain patients, penile plication sutures may need to be applied. In the malleable prosthesis that we apply, it may be much easier because we can use it even after application of the prosthesis. Or we can go into incision and grafting as required. Penile prosthesis insertion has good outcomes in over 80 to 90% of patients, even with Peyronie's disease. And the statistics clearly demonstrates that there is no major problem with Peyronie's disease and penile implantations as far as infection rates and others are concerned. So, in conclusion, ladies and gentlemen, when we are looking at surgical correction of penile prosthesis, we got to make sure that the couple are in clear opinion that they would want to consider surgery for the correction of this disease. We need to assess the stage of disease, acute versus chronic, the severity as far as the angulation, the indentation, and we need to have a clear indication of what is their erectile function, and what about the patient expectations as far as length, the possibility of length loss, the rigidity, and the curvature. And we also need to look at what is the surgeon comfortable at doing? What type of plication, incision, excision, and grafting? And also we need to look at cost factors. Thank you very much for your patient listening.
Thank you, Ajith. You can take a seat. So now the entire symposium is open for discussion. So you can direct any question you have to a specific speaker or in general.
Hello. The worst nightmare in, sorry. Does anyone have any idea why lithotripsy should work in ED? Is there a theory behind why it works?
The theory is that it is creating new blood vessels, so they think it might be angiogenic, yes. But whether that is strictly true, I think is difficult to really know, because of course the studies have been relatively poorly designed. But that's supposed to be the theory, yes. While I'm on my feet, Ajith, could I ask you a question? Do you do much grafting here in Sri Lanka for Peyronie's disease?
To be honest, I think the degree of deformity that we see in Peyronie's is much less than what we used to see over in the UK when we were over there. But if we do have to graft, we generally do use autologous, probably the GSVs.
Yeah.
But I think if we have to operate, it's mostly plication. And if it's grafting is needed, we do use more the autologous grafts for this, yes.
Yeah, I'd agree. I think we're grafting fewer and fewer as well now. I think there's an increasing acceptance that even if you have a pretty significant curve over 60, if you correct them maybe to 20 or 30, they'll still be functional, and they can avoid a grafting with all of that inherent risk of erectile dysfunction. I mean, I think the European guidelines quote 50%, which is pretty staggeringly high, so we're feeling the same. Thank you.
I think it's counselling, isn't it? You need to counsel these patients. And so when you weigh up, the problem is a lot will come in saying, oh, I've heard about the grafting and it's the lengthening procedure. My penis will be bigger, which is not true at all. It is not a lengthening procedure. And so once they know that, maybe what your aim should be is straighter rather than straight, accepting 1 centimetre, rather than a big operation where they're going to have significant ED. I don't think I've met many men who've had a LU procedure who are massively happy.
Okay, Helen has a question.
Yeah, I'm interested in the risk of Botox in the cavernosal space. So we put it in the detrusor all the time. It's you're not going into vascular spaces. It's interesting, isn't it, that we're not seeing cases of temporary paralysis, but does it worry you about that risk?
Yeah, I think it's another one of those things, isn't it, that see Botox, we'll put it anywhere at all, in the hope that it looks smoother and firmer. So, yes, I agree. It feels counterintuitive, doesn't it? But it clearly has some, at least, short-term benefits. Yeah.
The other thing I'm interested to ask the panel is, we've got this very significant rise in metabolic syndrome. How much of that is a factor in rising infertility? Obviously, it's a big factor in ED. Do you want to comment on that?
I think when it comes to fertility, you see these men, they come through their door, they're very big, they're quite fat, the testicles sit high in the scrotum, they overheat. So weight gain is a big issue for testicles keeping cool. What is their diet like? The amount of processed food they're eating. We're eating so much rubbish in our diets these days. Absolutely has an issue for fertility, and trying to change people's nutrition status is really big. Just like with erectile dysfunction, and I'm sure you all do it. If a man walks into my room complaining of new onset erectile dysfunction, it becomes a cardiovascular exam as well. They need to get warned. This is a warning sign that in approximately 5 years, you will start to run into trouble with your heart. And I think as andrologists or urologists, it's really good that we have that ability to make men change their lifestyles. And actually warning someone that their erections might be worse seems to make more of a difference in saying they might have a heart attack, in terms of making things better.
Yes, I think metabolic syndrome is becoming so common, particularly in the UK. I think there's only about 3 or 4 of us who don't have it, and we're all in this room.
If I could ask a question, Philippa. You mentioned about FSH and the HCG. Do you deal with that as a urologist yourself or the endocrinologist?
So I think if you're not comfortable or confident doing it, then you should definitely find an endocrinologist. I do a lot of it, so I do it all myself, but there are some fantastic endocrinologists out there who are very happy to support. The problem is too often patients are going off and taking these medications by themselves. You can get clomiphene, you can get HCG in your gym. They're not taking it carefully, or they're doing it in quite a bad way, and there are risks. So clomiphene has a risk of DVTs, clots. You need to be assessed properly. So I do, but I would say if you don't do it regularly, then find yourself an endocrinologist.
So Ian, just to sum up the questions.
Good afternoon, it's Supun here. This question goes to Ajith. It's about the suture material you use for flycations. Do you still use braided polyester for your flycations? I've seen most of the time it was the PDS these days. Do you still use polyester for the flycation?
Yeah, my personal use is the polyester 2O, the braided material, and probably superficial suture with 4O PDS to cover that as well.
PDS here?
Yes, I use PDS. When I first started, I did use some Proline, and then I spent the next couple of years taking those Proline stitches out because they do wear through and people can feel them. So I'm definitely PDS, yes.
Supun, what's your practice?
I've seen many applications, but they all use PDS always.
Okay. Right. So in the absence of any questions, we'll sum up the session. It has been very interesting and historic. So as we have given away the tokens to the 2 overseas delegates, that leaves only 1 speaker for the token. Thank you for participation.
Thank you.
Come up with another gift for Professor Ian Pearce. So, come. I think there's going to be some exchange of presents. I think I'm also going to get one. Because in his bag there is more than one. I think this time Sri Lankans in for a treat. For 1 tie we get 3.